Hello my dear students, a good greetings from me. I am Dr. Sayee Ganesh, professor from the Department of Periodontology and Implantology. I came here to teach you and discuss about the periodontal pocket, which is a very important chapter in the field of periodontology. Now I am going to discuss about what is the periodontal pocket. Periodontal pocket is the pathological deepening of the gingival sulcus. So what is called gingival sulcus? Gingival sulcus is nothing but, you can able to see here, a gingival sulcus is nothing but a shallow space that is bounded one side by the epithelium and another side by the tooth surfaces. It's a V-shaped surface, and histologically it is mentioned by Orban as 1.8 mm, but clinically it is about 3 mm. So normal sulcus depth is 0 to 3 mm for our clinical reference. So when it is more than 3 mm, it is called as a periodontal pocket. With the help of using the probe, we have to probe it out and find out the more than 3 mm means that is a periodontal pocket. That is one of the important vital sign for our periodontitis. The periodontitis is a very important disease, or it is the must disease in periodontology. The periodontology is running around the field is periodontium. It compromising of cementum, alveolar bone, 2 hard tissues and 2 soft tissues, that is gingiva, and another one is periodontal ligament. It made up of connective tissue and Sharpie fibers. You may know all this thing. So we are dealing about the periodontium now. So the disease or inflammation that occurring in the periodontium is periodontitis. We have to find out whether it is suffering from periodontitis or not with the help of a thing is called as a periodontal pocket. That is a clinical significance in this thing. It is very important for your clinical knowledge and for practical examination as well as for your theory examination. So pocket is a pathological deepening of the gingival sulcus. Then how do you classify the pocket? The pocket can be classified into 2 types. One is a gingival pocket, another one is called as a periodontal pocket. So gingival pocket means otherwise called as a pseudo pocket or false pocket, or not a true pocket or not a periodontal pocket, because you can able to see the pathological deepening of gingival sulcus means there is a loss of epithelium, junctional epithelium from cemento-enamel junction. You may all know. That is called loss of epithelial attachment. That is called as a periodontal pocket. But in this case of the pseudo pocket, we can able to see it out due to the gingival enlargement. Enlargement can be caused due to the acute or chronic gingivitis, or due to some systemic diseases, leukemic gingival enlargement, vitamin C deficiency, scorbutic gingival enlargement, and also there is a possibility of drug induced like phenytoin sodium and other type of the drugs. So this type of the enlargement causes the coronal. Coronal means the top position, not a bottom. Coronal proliferation of the marginal gingiva, but you can able to see the junctional epithelium is attached at the cemento-enamel junction. There is no detachment is there, so it is not a true pocket. When you probe it out, it seems to be like a more than 3 mm, but there is no histopathology or pathology is existing in this thing. That is for the pseudo pocket. When you come to the periodontal pocket, there is a loss of epithelial attachment, that is junctional epithelium, because there are 3 layers of the epithelium will be there. When you see the gingiva, macroscopically you can able to see attached gingiva, marginal gingiva, then sulcus, as I discussed now. And microscopically it is made up of epithelium and connective tissue. So the epitheliums are nothing but oral or outer epithelium, and sulcus is bounded by sulcular epithelium. Then the end of the area, that is a terminal area of the sulcus, is called as a junctional epithelium, which is a very classical feature in our dentistry. It get attached to the tooth surface, not to the soft tissue surfaces, and that is called cemento-enamel junction. So that junctional epithelium attached to cemento-enamel junction is the very important point. So when there is a loss is called as, that is called as periodontal pocket. So you may all know this thing in your introduction class itself. So this periodontal pocket means when you clinically probe it out, it shows more than 3 millimeter. So it can be of two types, furthermore classified into, because it not only affecting the epithelium and connective tissue, but also it affecting the other regions like underlying alveolar bone, you may know it out, alveolar bone surrounding the tooth, am I right? And cementum also, the two are. So it can produce damages as a vertical or angular bone loss, otherwise there will be a horizontal bone loss. You may know the classification of periodontal diseases, that is aggressive type of periodontitis, another one is called as a chronic periodontitis. Those are discussed in the previous classes. So the aggressive periodontitis, there is a vertical or angular bone loss due to his rapid onset and progression. Chronic periodontitis, it is very slowly progressive disease. There will be a horizontal type of the bone loss will be seen there. So depending upon this type of the two type of the bone losses, we are classifying the periodontal pocket into suprabony pocket and infrabony pocket, and you can able to see in the slide itself the infrabony pocket, the base of the pocket, that is the base of the junctional epithelium detached from cementoenamel junction is located above the crest of the alveolar bone. Okay. So located below the crest of the alveolar bone. Then in this case of suprabony pocket, located above the alveolar bone. So the base of the pocket is located below the infrabony pocket, suprabony pocket located above the crest of the alveolar bone, because it is a vertical bone loss in the previous condition and it is a horizontal bone loss. So this differentiates into suprabony, infrabony pockets. So I want to explain about those things, what is gingival pocket and periodontal pocket and how it happening, all these things. We are proceeding into what are the differences between these two type of the pocket. I explained these things in this thing, that is suprabony pocket means there is a supracrestal or supraalveolar. Infrabony pocket is called as a subcrestal or intraalveolar also there, and you can able to see there is a horizontal bone loss in suprabony, vertical bone loss, mostly angular bone loss, vertical bone loss in infrabony will be there. The lateral wall consists of soft tissue alone. You know, I think the pocket has two walls will be there. One is the base of the pocket, another one is the lateral wall of the pocket, lateral side or lateral wall of the pocket. These two things are very important in your future deciding the progression of the periodontal pocket. So the lateral wall consists of soft tissue alone, but in the case of suprabony, but in the case of infrabony, because the base of the pocket is below the level of the alveolar bone, crest of the alveolar bone, crest means the peak of the alveolar bone. So there will be the lateral wall will be consisting of soft and the angular defect alveolar bone. So this should be taken into consideration. When you come to the interproximal areas, one is the transeptal fibers will be there. Transeptal fiber, you may all know it out. In between the two teeth, above the crest, they are transeptal, they are transversely passing above this thing. It will discuss in your gingival and periodontal ligament chapter. So these fibers and transeptal fibers are horizontal in this case of suprabony pocket, but in this case of infrabony pocket, there will be a possibility of angulation or obliquely they will be oriented. In this case of facial lingual surfaces, there you can able to see the periodontal ligament fibers follows horizontal and oblique course in this case of the suprabony pocket, but in this case of the infrabony pocket, you can able to see it out. In this case, there will be a angular oblique in this case. Then we can able to depend upon the surface area. We have to classify the pocket into simple pocket, compound pocket, complex or spiral pocket. Simple pocket means it involving the only one surface. You know it out all better than me. The tooth is surrounded by the four surfaces, four walls of the bone, buccal wall or labial wall. We can able to say mesial wall, distal wall on either side. Then in this case of upper means the palatal, lower means lingual wall. So only one area, one surface, one wall, one area, it will involving one surface involving mean that is simple pocket. Compound pocket mean more than one, 1 plus 1. It may be a buccal wall and also mesial wall, or buccal wall, mesial wall and lingual wall also. So like that it will more than one is called compound. Then complex or spiral pocket. What is complex or spiral pocket means? They are having interconnection between them, because in between the bone is between the two root or around the root will be more damage will be taken place. So what will happen? They have the communication between each and everything. So they are originating from one surface, ending another surface. They are also a compound pocket only, but they are having interconnection. So this is the thing you have to know it out. During the periodontal abscess, destruction, other things, you can able to see complex pocket can be seen there. Then in case of healing lesions, there will be a possibility of after the inflammation and infection, there will be a destruction and construction phase will be there. Suppose the healing, our immunity power is very good, the construction will be there, it become more fiber optic, the tissues become more fiber optic. The destruction means you can able to see it out, it is like edematous. It is like edematous, you can able to see it out in this area. Next one, some of the clinical features we want to discuss it out. So when you see it, these are very important for your clinical case sheet discussion. You can able to see whenever the pocket is there, first we can able to see the collar, dolar, ruber tumor. These are the 4 cardinal signs of inflammation. You may know it out, what are the relative terms, synonyms in this case of general pathology itself. So there will be a color change will be there because it's an inflammatory process. Inflammatory process takes place in the 2 areas. One is acute inflammation and chronic inflammation. They are having the 2 phases. One is cellular, another one is called as a vascular. First take place is a vascular. So there is a more amount of blood supply to that area will be taking place. So there will be a redness will be there. Normally the gingiva color become more reddish in color, and in the case of chronic, due to the venous stagnation, it become bluish red in the color. That only mentioned as a bluish red marginal gingiva, and due to the collection of the fluid in that area, it become edematous, enlarged, and you can know it out. There will be a attached gingiva should be, we can able to see it out, the parabolic shaped or C wave like that. And in this case, you can able to rolled out gingival margins will be there. In this case of pocket, reddish blue vertical zone will be there. And due to this thing, there will be a very damage will be taking place in the bone, alveolar bone also. There is a possibility of what is called extrusion, migration, mobility will be taking place in this area. Mobility will be graded grade 1, grade 2, grade 3. Grade 3 is going for extraction only. Okay. You can know all these things that will be discussed in the future coming chapters of clinical discussion. And in the case of the soft tissue, when you're discussing, it looks like a shiny puffy gingiva because of the edematous fluid collection, edema. And there will be one of the important cardinal signs is gingival bleeding will be there. The gingival bleeding is one of the acute inflammatory sign. As we all know it out, chronic periodontitis is a disease of what is called as it having the activity, inactivity. Sudden activity, sudden inactivity will be there. So find out the activity that is called as a acute inflammation. The bleeding on probing will be there. This bleeding on probing is masked during the time of cigarette smoking will be there because of vascular changes. So we have to see other signs, inflammatory signs, to check it out whether it's acute inflammation. This is one of the clinical tip you have to take it into your notes. Then there is a possibility of purulent exudate will be there. Mostly there will be a exudate mean you may all know it out with the help of digital pressure applying upon the attached gingiva. The pus like the serum will be coming out in that area. Exudation will be coming out in that area, different the protein concentration will be there, that is purulent exudate will be there. And you can able to see the collection of this exudate in the area is called abscess. And I want to mention an important clinical sign in this area when you are having a suffering from diabetes mellitus, because diabetes mellitus is having a bilateral connection with our, as in the perio-medicine latest emerging field, connection with our periodontal diseases. So periodontal diseases is having a more amount of the periodontal damage is there or periodontal inflammation is there. Diabetic HbA1c will be increased. You may all know 3-month mean value of the sugar level, blood sugar level. At the same time, when the blood sugar level is increasing due to the C-reactive protein from the liver, there is a possibility of our periodontal inflammation will be overheaded. So this should be taken into the point of consideration. So multiple periodontal abscess will be the one of the clinical feature for the diabetes mellitus. It is very important MC question for your point of theory examination. Now we are coming to that area. What are the methods of probing? How do you find it out? There, before going into the methods, we have to see about the 2 type of the probing will be there. One is a biological depth, that is called as a histological depth. It is nothing but distance between the gingival margin of the gingiva to the base of the pocket, that is nothing but, as I told you, it's a junctional epithelium, coronal head, end will be the base of the pocket. When you come to the clinical probing depth, that is called as a proper probing depth, it is a distance from the gingival margin till probe penetrates. That should be taken into consideration. Then we have to see it out, the bold letters given 0.75 newtons or 25 grams or 25 pounds, PONDS. Okay, these are the probing force you should know. This is very important viva question for your examination point of view. Now we are coming to that area, how do you probe? The probe should be parallel to the long axis of the tooth. Mostly we are using the probe is called as graduated Williams periodontal probe. It's starting the marking from 0 to 10 and it having the absence of 4 and 6 will be there. Why 4 and 6 will be absent? You may ask me the question, because I told you in my first slide itself, first beginning itself, 0 to 3 millimeter is a normal sulcus depth, that is a physiology. When it becomes pathology, when you probing out, it becomes more than 3 millimeter. That should be taken into consideration. So, for avoiding the confusion, the 4 will be absent. Then why 6 will be absent? There will be a shallow pocket and deep pocket will be there. When there is a shallow pocket is there, you may all know it out. Non-surgical procedure, non-interventional procedure like scaling, root planning, local drug delivery system, laser with the help of laser photodynamic therapy, so many things can be done without elevating the flap, surgical procedure. So, when that for the purpose, the 6 will be absent, up to 6 will be shallow pocket. You can use all the your non-surgical procedure as in the case of phase 1 therapy, as we discussed in our clinical case sheets. Then when you come to that area, when you go to above 6 millimeter, it should be a surgical flap elevation, interventional procedure has to be done, or we have to go for any regenerative process, GTR, bone grafting, other type of the modalities, higher advanced methods can be done with the help of flap surgery only. That is coming in the surgical phase, phase number 2. So this is very important tips. Usually in the clinical internal examinations, they will ask you these questions and external will ask these questions, make the note the point of this thing. And we can able to find it out, the probe will be 3 generations will be there at for your now at present, and 4th and 5th under the research will be there. But we are discussing those things in the diagnosis chapter, so we are not going deeper into the thing. So relative things, what you know it out, I want to discuss here. We have to keep the probe parallel to the long axis of the tooth and you have to probe it out towards, adjacent towards the tooth surfaces. Yeah, there is one method is called walking of probing. Another one method is called taking 6 index point. Walking of probing means from mesial border to distal border in the buccal surface. Take the probe to walk slowly in the speed of 25 grams. Okay, and find it out. If the pocket depth is more than 3 millimeter, you have to note it down. Then at the same time on the lingual side or palatal side, maxillary mean palatal side, you have to walk your probe from mesial to distal side and find it out this thing. Then you have to count it out. What is the maximum score for this thing? For an example, one score mesial is showing 3 and middle is showing the 4 and distal is showing the 6, means the 6 is a score for particular tooth. This is for your clinical tip in a clinical case sheet writing. And when there is a probing pocket depth is there, that is a true pocket is there, you have to write the Russell's periodontal index, you may all know it out in the clinical case sheet writing, should be a 6. If there is X-ray is there, radiography is there, if there crystal bone loss is there, it can be interpreted as a 4 or depend upon the crystal bone loss. Otherwise, it will going for a 6 only with the grade 1 and grade 2 mobility. If it is grade 3 mobility, mobile in all direction, go for score number 8. So this is one of the clinical tip I want to spare it in with you. And another one probing method is taking 6 index point, mesiobuccal, midbuccal, distobuccal on the buccal surface and also in the palatal for the maxillary and lingual for the mandible, and maximum score should be taken into consideration. When you coming to the multi-rooted teeth, you know it out furcation. For finding out the furcation, the curved probe, Neighbors probe, NABERS, that is very important. That can be important to you because it's nothing but the involvement of the periodontal disease, extension of the periodontal disease downward towards the furcation area, that's due to the anatomy, that is called furcation involvement. It is nothing but the periodontitis only. So that should be taken into consideration. The next one I want to show something to you. That is, there are three pictures has been mentioned in this area. That is how the probing depth and attachment loss will be there. You can able to see it out. The loss of attachment is measured from the base of the pocket to the cemento-enamel junction. These are the two important areas you have to know it out. The cemento-enamel junction till the probe penetrate is called as a loss of clinical attachment loss. Why it is called as clinical attachment loss means is having the hard tissue reference, that is called cemento-enamel junction is there. And when there is a marginal gingiva covering over that thing, that is called as the periodontal probing depth. That is from the marginal gingiva till probe penetrate to that area. So the soft tissue can able to bulge out, or during the time of the recession it can be atrophy also. So we can't able to put it out in the correct way. For the thing, we had the hard tissue reference, that is cemento-enamel junction. Mostly normally in the normal gingiva, you can able to see it out the 0.5 to 1 millimeter above the gingival margin will be above, located above the cemento-enamel junction. This is one of the clue will be there. Here you can able to see the probing depth will be around 1 to 2 millimeter. All the probes are measured in that area, but you can able to see in the first condition, you can able to see the cemento-enamel junction is not at all detached. Second condition, 1 millimeter detached will be there, or 0.5 to 1 millimeter. Third condition, that is called recession, that should be taken into consideration. There will be a 1 millimeter probing depth, but from cemento-enamel junction another 1 millimeter will be there. The two marking will be there, that should be taken into consideration. So when you taking the recession cases, those cases are considered as a score number 6, or X-ray will be there, score number 4 will be there, radiography will be there. Why means because there are two things we have to take into consideration. One, what is a recession? Apical migration of marginal gingiva, exposure of the root portion. Root portion is covered by cementum. Cementum is coming from which origin? Mesodermal origin. You can able to see our embryology is telling, human embryology is telling, all the epithelium, ectoderm tissue epithelium all coming from ectoderm only. Whenever the mesoderm is exposed outside, it's not a physiology, pathology. That is for the human anatomy and embryology theory. But when you come to our periodontal field, you can able to see the loss of epithelial attachment. They are mentioning the true pocket means there is a loss of epithelial attachment. I told you beginning itself, introduction itself. So the junctional epithelium resided downward from cemento-enamel junction. You can able to see. So in the recession also it resided downward. So that is a pathology. You have to put score 6, or in the radiography is there, score 4 will be the depend upon the bone loss and depend upon the progression and stages of the disease. You can able to see it out. So you have to not only probing depth will be 1 or 2 millimeter, less than 3 millimeter, as I told you. Like that you can't able to say it's a physiology. You have to, when the recession is there, you have to take from cemento-enamel junction. You have to take the hard tissue reference. At the same time, when there is a gingival enlargement is there, you should not confuse yourself, because the coronal proliferation shows you more amount of the probing depth. That also taken into the cemento-enamel junction. So this is cemento-enamel junction is very, very important for these purposes. Here the diagrams are mentioning about the various constant probing depth with the different level of attachment loss. You can able to see first one 0 mm attachment loss, 2 mm probing depth will be there. And this case, the second picture, the top second picture is showing it. There will be attachment loss, that is from cemento-enamel junction. There will be, you can able to see it out. There is a, so you can able to see 1 mm attachment loss will be there. Then next one is the 2 mm will be the probing depth will be there. Here you can say the 0 mm will be there. Here 2 mm will be there. And you can able to see here, there is a recession is there. You can able to see apical migration of marginal gingiva, exposure of this root portion, sometimes is exposed. This is a cross section, you know it out. This is called enamel, this is called dentin, this is called cementum, this is called supracrustal fiber, the gingival fibers as we know. This is called periodontal ligamental fibers, principal fibers, alveolar crust, and bone will be there. This is a epithelium, this is a connective tissue. Okay, ground substance, other things will be there. I am not going detail in this thing, just for the brief up. Okay, this is will be from cemento-enamel junction. Here you can able to see the junctional epithelium. You can able, this is a junctional epithelium, you may all know it out. Instead of keeping here, it coming out here. So 4 mm attachment loss will be there, but probing depth 2 mm will be there. What do you mention in this thing actually? Did you put for a score number 1 or 2 like a gingivitis and Russell's index, or it can be without X-ray? We are discussing. It will be 6 or 8. Okay, it will be around 6 only, because you should add up from cemento-enamel junction this 2 millimeter, another one 2 millimeter, 4 mm should be added up in that area. That only the count. 4 mm means that is called more than 3 millimeter. That will be pathology. This is one example I want to mention to you. Next one is also you can able to see constant level of attachment loss with different probing depth. I am talking about probing depth and attachment loss with probing depth. Here the probing depth is constant 2 mm. There is no pocket healthy. Here there is a no pocket, only 1 millimeter will be there. So 2 plus 1, 2 will be there. And here you can able to see this is sulcus. This here the residual recession is there. So it will be a pathology. But probing depth is 2. This should be very important to you. Next one I want to discuss here. 7 mm will be the probing depth will be there. But you can able to, this is a pocket actually. Okay. Here also there will be a clinical attachment loss will be there, but it will be hidden in that area. It will be found to be 3 mm from cemento-enamel junction, because this cuff of the gingiva is hiding this thing, hiding this thing. Am I right? Then next one you can able to see some shrinkage will be taken place. There is no partial hiding will be there. Or same 3 mm attachment loss, 3 mm probing depth will be there, but you can able to see the space will be vacant here. But both are same only. You can able to see the attachment loss, constant level of attachment loss, different probing depth. Here the probing depth will be, you can able to 0 mm. The recession is taking place. Here also from cemento-enamel junction, the junction will be resided downward for about 3 mm. So all threes are same. You can't able to say this is a physiology. There is no core number 1 or 2. You can't mention the Russell's index. Here you can mention 6 or here you can mention 6. But both are, all three are same. Just for your clarification, I am giving this picture to you. Okay. So this is a point we'll made mostly we can commit mistakes in this thing. So these two things you should know. Cemento-enamel junction, that's a clinical attachment loss, level or loss. At the same time, there's a probing pocket depth, especially recession and gingival enlargement, that is a overgrowth of gingiva. It should be taken into consideration. Okay. This is very important clinical tip I want to mention to you. Next one, this is nothing but relationship of attachment loss and bone loss to the pocket depth. You know what is a pocket means? The pocket is a pathological deepening. It you can able to do the degree of attachment loss depend on the location of base of the pocket on the root surface, but the severe rate of attachment loss generally correlated with the depth of the pocket will be there. You have to know it out. The pocket is nothing but loss of attachment gingiva, denudation of the root surface. Both the things will be there. When there is a recession associated with the pocket will be there. So, an example, the probing depth of the pocket will be 4 to 5 mm will be there, and recession also there. Means then there will be more damage will be taking place. This thing will be mentioned in this slide. Now we can able to see I am talking about the clinical features in this slide, and next slide I am talking about the histological correlation for this thing. How it looks like. For an example, the first one is a bluish red discoloration in that gingival pocket wall. What is the correlation for this thing? I mentioned this thing. That I told you the inflammation is made up of acute inflammatory, that is you can able to see it out in the first beginning itself. I told you there will be a stagnation of venous stagnation. So color will be changing from acute inflammation to become red, it become bluish. That only mentioning in this thing. The reason is circulatory stagnation. When you go back to the same slide, another feature is flaccidity. Then what will happen in this area means there will be a destruction of the gingival fibers. I told you the what is called as a supracrustal fibers and other surrounding fibers will be there. The next one is we can able to see it out is a smooth and shiny surfaces, very smooth surface, because you can able to see it out. Stippling is one of the classical feature you can able to see in our clinical thing. Orange peel like appearance when you dry with a small pellet of the cotton, the attached gingiva and central portion of internal papillae, that is can't able to see smooth shiny because of the inflammation. Reason is due to the inflammation, degeneration of the epithelium, atrophy of the epithelium will be taken place. That should be taken into consideration. The next one is the pitting on pressure. Pitting on pressure will be there. Firm and firm gingiva will be there. These all are due to the fibrotic changes predominant over the exudation degeneration. You can able to see it out here, and the pink gingiva due to the increased vascularization and thinned out the epithelium because of the what is called inflammation. There is atrophy of the epithelium and thinned out epithelium, ulceration in the epithelium, engorged blood vessels will be the acute inflammatory signs will be there. So that's one of the reason for there will be a possibility of ulceration as well as bleeding will be there. So engorged blood vessels and the thinned epithelium, bleeding will be taken place in their area, and the inner wall will be painful, when you probe it out, painful, pus discharge, all the things are correlated with the engorged blood vessels and the thinning out of the epithelium and ulceration, micro ulceration, the inner wall of the pocket, that is the epithelium of the pocket, and the separation, the fluid collection is coming from the connective tissue and into the gingival sulcus area or gingival margins. These are the things, the correlation between the clinical feature and histopathologically. What is a pathogenesis for this thing? Because very important question to you. It's important 5 mark and essay question also. The pathogenesis playing a dominant role. We can able to say it all are due to the inflammatory. Periodontal disease is a chronic inflammatory disease having a multifactorial etiology. This is a very important point I want to mention you. So this should be, you have to, when you write about pathology or there is a pathogenesis, you have to keep this mind, chronic inflammatory disease and multifactorial. That should be the very important point, key point, you have to keep it out. So what will the inflammation will changes in this thing means, the inflammation will be taken place, you know it out very clearly, plaque and calculus, you know it out. Supragingival plaque is dominated by cocci, then become subgingival, become aerobic, become anaerobic, and cocci become rods and bacilli. They can able to produce noxious, and we can able to see it about the virulent factors will be there. They irritate the what is called a sulcus area, the bottom of the sulcus, the junctional epithelium, they get into the thing. So inflammation is starting out from the epithelium and it occurs in the connective tissue wall of the gingival sulcus. Then what will happen? The cellular and inflammatory exudate cause degeneration of surrounding connective tissue and gingival fibers below that area of the what is called junctional epithelium. Then it will proceed downward. The collagen fiber destroyed just apical to the junctional epithelium. At last, the inflammatory cells are infiltrated, edema will be taken place like polymorph and neutrophil, etc. These are the 4 steps in the pathogenesis. We want to discuss how this will be taken place in that area. You can able to see it out. I want to draw a diagram to you. This is the enamel cross section. This is dentin. This is called as a cementum portion will be there. And you can able to see here the gingiva will be attached. This is called as a junctional epithelium. This is called as a circular epithelium. This is called oral or outer epithelium will be located here. Okay. This is called a circular epithelium and it is get attached to the area is called as a what is called as cemento-enamel junction. So here supragingival plaque calculus plaque will be there. It become calculus and the subgingival also coming out. It irritate the gingiva. Once irritated, the dendritic cells and other things you know it out all these things. Okay, these are supracrustal fibers having a origin, not having the insertion. These are called as a periodontal ligamental fibers. These are the alveolar bone and here the peak of the bone, the crust of the alveolar bone will be located here. The crust will be located here. Okay, so you can able to see it out. This microorganism enter into the virulent factors and toxious, what is called as enzymes, other things are entering. You can able to see acute inflammatory cell. You know what is acute? It's a very important MC question. Acute inflammatory cell, that is called polymorphoneutrophils. Chronic inflammatory cells, what is called chronic inflammatory, that is cells are called as nothing but what is called as a lymphocytes. Am I right? Lymphocytes will be there. Okay, so what will happen once this margins are irritated, okay, you can able to see there will be a permeability will be there. That permeability will be widened or increased, so it get into that area and just apical to that area they can produce inflammation. When the immunity power is, that is called, you can able to see dendritic cells are sensitizing this thing, you can able to see the perivascular, the surrounding the vascular, the perivascular tissue will be there. That cells are recognizing this thing and they can producing the what is called histamine like that, histamine, you know it out like that, okay, and prostaglandins, you know it out. The can arachidonic acid extract will be there. These are the beginning stage of inflammatory things will be there. These will be causing the other cellular lymphokines, or we can able to see about, you can able to see interleukins like pro-inflammatory interleukin 1 or interleukin 8 and tumor necrosing factor, etc. will be coming out from that all that area. Side by side the cell vascular changes, more amount of blood supply to that area will be there, you know it out. The blood cells are coming out and widen enough and WBCs are coming out, that is a polymer of neutrophils are coming out and fighting against this area. What will happen due to the inflammatory markers, whether the fighting is doing good means the inflammation resolved, infection is resolved and you become normal, healing will take place. If it is not means what will happen, more amount of the WBCs are coming out in that area, first 15 and it become 25, then it reaching 60%, you know, at the time totally these normal tissues are filled with the help of all the WBCs will be there. That is the biggest factor. Then on possibility micro ulcerations will be there. You can able to see finger like projection from the epithelium. From epithelium there is a finger like projection will be there. Micro ulcerations will be taken place in the connective tissue area, because you know it out very important. Connective tissue does not have very good blood supply. It is a last layer, is a germinal layer. You know it along the 4 layer. It get the blood supply and metabolic extract only through help of the underlying connective tissue only. You know it of those things. So once the inflammation, there is a what is called fluid collection in between the cells and between the epithelium and connective tissue, there will be a less compromised blood supply, less or compromised blood supply will be there. That is one of the oxygen supply will be there. That is one of the drawback. Along with this thing, the immunity power also not functioning. Pro-inflammatory will be there. Anti-inflammatory is coming out. Cytokines there. There is a big problem will be created. Automatically, the connective tissue has been lost here. Then they further produce into the bone, where you can able to see the bone, the coupling. You know the thing, bone remodeling, rankle. You know it out. I don't want to go into the OPG. This will be activating for the bone destruction will be there. So this is a way the pathogenesis of the pocket will be taking place. I give the outline to you. I'll further proceed into my next slide. So here you can able to see the plaque will be located here, and they are coming out here. Okay, and you can able to see, as I told you, my picture is, my drawing is not clear, mean you can able to see this picture, single picture. You can able to see a finger like extension will be there. These are the cells, endothelial cells surrounding the endothelium, you know it, or surrounding the blood vessels. That's a vascular supply. They can produce a histamine and other things like that also. You can able to see it out, so many what is called as inflammatory, anti-inflammatory cytokines are growing out, and you can able to see acute inflammatory cells are coming out in that area, fully filled that area, and the micro ulceration will be there. Loss of what is called as a collagen fibers will be there. You can able to see the collagen fibers will, degradation of collagen fibers will be there. These are cord like projection will be there. Due to the cord like projection, what will happen? Apical extension or detachment of the junctional epithelium from the subutana junction coming down. That's the reason that this is called base of the pocket. That's the reason it's coming out, and this is the lateral of the pocket will be there. And you can able to see it out. The other type of the cells after the lymphocyte become a T and B lymphocytes will be there. You know everything. The plasma protein, other things has to come in. The antigen antibody reaction has to be coming to that area. Then mast cells become macrophages, and you can able to see all the things are coming out. They can able to, the macrophages can able to activate upon the bone by the help of bone coupling, OPG, I told you in my previous drawing itself, and also rankle itself. They can also produce the what is called as a matrix metalloproteinases and tissue inhibitor of matrix protein. All the things are as like a cascade will take place, and who are the winner? The winner will be, if your immunity is the winner, then the pocket will resolved or it will be healed down. Otherwise, if it's not mean, further progression will be there. This is the pathogenesis of the pocket in a brief outline. So now we are able to see about what are the cellular, I told you in my first slide, is cellular inflammatory changes exudate will be there. The fourth point of the previous slide. Here you can able to see the cellular and the inflammatory exudate, degeneration of connective tissue fibers, and connective tissue will be taken place in the area by the help of two mechanisms. I told you in previous picture itself, matrix metalloproteins. There are so many matrix, but collagenase, they tell it out in a colloquial name or a much simpler name, but proper name is matrix metalloproteinases. They are having so many varieties will be there, and our, you know it out, the periodontal ligament is made up of collagen 1 and collagen 3, like that, so many things will be there. So they can able to produce out here matrix metalloproteins. That is by the two authors are found out those things. Okay, and what will happen? Then there is a possibility of phagocytosis. You know, phagocytosis engulfment of the foreign material by the polymer neutrophils. So what will happen? The apical cells of junctional epithelium, as I told in my previous things itself, the finger-like projections will be taken place. Then detachment from the coronal portion is of the junctional epithelium detached from the subutana junction further downward, and there is a 60% of polymorph neutrophils. So there is a loss of cohesiveness will be there. So the sulcus shifted apically become pocket. This is the mechanism you want to know it out. Then what are the epithelial changes you have to come across? Now we are coming to the microscopic level. What will happen? Epithelium, I told you finger-like projection, like that I told you that what will happen to the finger-like projection mean there will be a degeneration will be taking place. Ulceration will be taking place. Thinning will be taking place in that area, and atrophy will be taking place in that area. You can able to see it out. And inner aspect of the pocket become ulcerated. So because of this, due to the changes, there is a pus discharge will be there. It is a suppurative inflammation of the inner wall. What will happen to the after the epithelium, the connective tissue? The connective tissue, what will happen? I told you previously, the collar, dollar, ruber tumor. Tumor means swelling. So what is a intercellular fluid collection will be there. And the connective tissue is densely packed. I told you 60% of polymer neutrophils. The polymer neutrophils increasing in the inflammatory cells, that is the biggest hurdle for the resolution of this problem. Okay, because it's inflammatory disease. That's the reason. So it's a acute inflammatory cells. So the connective tissue become edematous and densely infiltrated with all the plasma cell, lymphocyte, polymer neutrophils. Then blood vessels are engaged, dilated and increase in the width and size. More amount of the blood supply is getting into that area. That's the redness is there, and there will be multiple or single foci of necrosis will be taken place in the connective tissue. That is, further destruction will be taken place, and the proliferation of epithelial cells with the newly formed fibroblasts in the healing process. Collagen fibers will be there if they are going to heal, or degeneration means the necrosis will be furthermore progressed and loss of damage will be taken place. Now we are coming to the area is called as what are the content of the pocket. The pocket is not very acutely inflamed or very seriously inflamed. We can able to see it out the debris. Debris is nothing but microorganism, their own products, endotoxins, metallic product. So the pocket content I told you debris, microorganism and their products I told you not just now. Along with this thing, gingival fluid, our food debris and salivary mucins, and whatever the epithelium is degenerated, it be and normally fall down, that's a discriminated, and whatever the leukocytes that has been destroyed, death, all the things will be contained in our pocket when you take a sample from the pocket. If it is having the purulent exudate is present, there will be living or death or degenerated necrotic WBCs will be there. Living or death bacteria will be there. Sometimes WBC can kill the bacteria also, and if the host immunity is very good, serum will be there, and some amount of fibrin will be located in this area. So these are the things you have to take in the content of the pocket. Is very important short notes to you. Now we are coming to the area surface morphology of the tooth wall of the pocket. We have to see it in the electron microscopy. These are the things you can able to see. The first, you can somatoenamel junction itself, it is in the sulcus area. First it is covered by calculus that are mentioned here. Next one is attached plaque. This has been covered by attached plaque, that is attached plaque 100 to 500 micron. Then it is unattached zone of unattached plaque. This is if you ask some questions to you, which one is an MC question, which one is more dangerous? Is a calculus or plaque attached or unattached plaque? You have to tell unattached plaque is very dangerous. Comparing to the calculus, plaque is very dangerous. Plaque is having an active form of the microorganism. Calculus is like an incubation zone, like a shelter. It get into the area of the microbes to be get into the thing. From this thing, noxious product can come out and damaging our own host products, host tissues. Next one is the zone of attachment of junctional epithelium. This is a junctional epithelium zone of attachment. So this unattached plaque will send all the what is the noxious enzymes and other products to it area, virulent factors that can destroy the junctional epithelium. That is a zone is reduced to 100 micron. You can able to see it out. Then there is below this portion, there is a partial destruction of the connective tissue that is called supracrustal fibers or gingival fibers, as we mentioned like that, and there will be intact collagen fiber will be there. Furthermore, proceed downward into the periodontal ligamental fibers. Then there is a bone loss will be there, depend upon the radius of action, depend upon the microorganism aggressiveness. There will be vertical horizontal bone loss will be taken place in that area. So this is a surface topography of the tooth wall of the pocket. So when you see about this is a tooth wall, when you see about the root surface, what are the changes that can be taken place in the root surface? That is important, because in our periodontal pocket non-surgical procedure and in surgical procedure open flap also, root planning, that is a root biomodification of the chemical or mechanical root biomodification, very important branch, because you may all know it out, the Sharpie fibers, you know it out, the Sharpie fibers will be getting attached. And when you come to the root surface wall, I want to draw one diagram to you. You know it out, the cementum will be located here, and here the cementum will be located here. Here the alveolar bone will be located here, am I right or not? So in between the cementum and alveolar bone, when you put it out, the fibers are running it, am I right or not? So when you put a diagram here, this is a cementum, I can able to put it out, cementum is there. This is the alveolar bone, I can put it out like that. This is alveolar bone AP. You can able to see the fibers are running like that. You can able to see in our book, Karansa also, Jan Linde also. And what will happen means, these fibers are getting attached to the what is called as the alveolar bone like a knot like that. You know it out, am I right? You know it out like that, the knot, it will be like that, okay? And the cementum also, it looks like a knot. How this will happen mean, you know it, a cementum is made up of the mineralized portion, this is also mineralized portion. What will happen, they can able to get into that area and they can mineralize that area, you know it out, okay? This is called Kibriform plate, the bone, you are able to see it out, and radiographically you can able to find it out, this thing, small holes in the bone will be there, that area, this fibers, the end fibers will be there, it's called Sharpie fibers will be there. So the Sharpie fibers are determining the periodontal ligament attachment to the cementum and alveolar bone. If the periodontal ligament is only attaching to the cementum, no use. If it is attached to the alveolar bone, no use. You can able to see it in the implant. When you come to the implant, what type of integration will be there? Previously, they are not properly, they are not armamentarium and other type of the technique they are not doing. So fibrous between the implant and the surrounding to the fibrous tissue, the connective tissue alignment will be there. Now the bone formation will be there, but when the connective tissue formation will take place, it is not in the perpendicular way, it should be in the parallel way. That's a problem with the implant, you know it out. That is a drawback we can get for periimplantitis. Loosening and falling, ailing and failing of implant will be there. But in the periodontal tissue, it won't be taking place. That should be taken into consideration for your good reference. When you come to the periodontal chapter, implantology chapter, you have to know it out. Implantology is one of the newly evolving branch in our periodontology. Am I right or not? So at the same time also, when the periodontal ligament is there, you know it out, that's a shock absorber, you know it out. And the periodontal chapter itself, that is a functions of periodontal ligament, it will be given like that in the periodontology chapter itself, the second chapter in your book, Karansa. So what will happen, it get the shock should be downward to the basal bone through the help of the what is called as a periodontal ligament fibers. So when you want to move the tooth from mesial to distal, orthodontic movement or whatever the 0.5 millimeter, every yearly it's moving out in the mesially or adaptation, functional adaptation, the cusp for grinding itself. All the things can be done with the help of the periodontal ligament. In this, when you are going for a treatment of the implant, means you have to be very careful about the above super structure, that is a prosthetic structure, because the occlusion is not proper, mean your implant will be failure, your implant will be failure, and also the delivery of the forces can't able to get into that area. In our single rooted teeth, delivery of the forces means root can be divided into three portions: coronal third, middle third, apical third. Middle portion of the middle third, apical third will be distributed like that. In the multi-rooted tooth, furcation area and the cementoenamel junction will be there. So these are the points you have to mention it out, and that's the reason in the case of mixed dentition period, implant can't able to do it out. The tooth will be can't able to migrate because the periodontal ligament, because the Sharpie fibers not attached. This is very important point. You have to clinical application, you have to keep it in your mind. So on seeing this thing, now we are coming to that area, root surface wall. As a tooth pocket deepens, the collagen fibers embedded in the cementum are destroyed. I told you what I told you. The cementum become exposed outside. Demineralization can be taken place in the area. Some of the remnants of the Sharpie fibers will be seen in the area, that also undergo the destruction. So the connection will be get lost. Okay, the creating the favor for the environment to that favor environment for the bacteria to grow in that area. So the penetration of bacteria into that area, they furthermore they also do the demineralization by the help of the acidic media, they produce acids, so many acid and demineralize, and they can get into the cementum area, okay, this area, and they can surrounded by the calculus, that is called calculocementum. Very important. 2 more question to you or MC question to you. Okay, so that is called incubation zone. Incubation zone mean something to be the microorganism should be set inside, that is surrounded by some cell like that. So your antibiotic or whatever you are doing can't able to do. That's the reason more than the antibiotic, systemic or local antibiotic, our mechanical debridement is the biggest thing, success in our scaling and root planning. That is very success in our periodontal pocket treatment. You have to know it out, this thing. Okay, for the purpose I am mentioning this, the clinical application I want to mention to you in future, apply in your clinic. So without root planning you can't able to, because you have to break the shell for the incubation zone, that only you can able to get it out. The next one is the same type of incubation zone, you can able to find it out in this case of the juvenile periodontitis, previously known as juvenile, now it's called aggressive periodontitis. This is an extra clue I am giving to you, because they are producing Agrobacter actinomycin comitant, previously it's called as Actobacillus actinomycin comitant. They can produce a toxins as the epithelial toxin, they can get into the epithelial penetration power is there. That's the reason previously they mentioned hydrogen peroxide mouthwash has to be given. Nowadays the chlorhexidine mouthwash has gold standard, both the bactericidal, bactericide depend upon the concentration that can be used. This is extra tips I am giving to you. We will discuss those things in your aggressive type of periodontitis. Okay, just you can keep it in this clinical point of view. Okay, so what will happen, there is a necrotic cementum will be created. So when you are doing the root planning of the thing, you have to remove the smear layer and necrotic cementum, and you have to take out the bacteria outside, so you are creating a good environment for the collagen to produce in that area, and they can get into that area. That's the reason why we are giving doxycycline to the most of the patients. The tetracycline doxycycline is one of the antibiotic we are preferring actually in the local drug delivery system also, and systemic antibiotic also, because tetracycline having so many folds, around 8 to 10 folds in our GCF, gingival curricular or circular fluid. That's one point. Second important point for doxycycline has a habit like chelation, absorption onto the calcium like that minerals. So it get into the root surface, and it having a anti-collagenetic activity. They can working against the matrix metalloproteinases, so the collagen fiber destruction will be minimized. Okay, so these are the clues, clinical clues I want to give it to you in your day-to-day practice. These are the application of these chapters in your clinics. Okay, we can proceed with the next one. So here I am coming to the end stage of my presentation. I think you may all know it out in a good way. I think so. I fulfill your needs. I think so. I want to give some of the clinical and also theoretical point of view. Defined pocket is important question for you during time of your clinical examination. Without knowing this thing, you can't able to pass. Number 2, or you can't become periodontist or dentist. Number 2, I want to tell to you, pocket and its classification is a short notes to you. And I want to mention another one important thing in this classification also. I told you about suprabony, infrabony. There will depend upon the walls of the pocket, 1 wall defect, 2 wall defect, 3 wall defect. Those things will be discussed in your patterns of bone destruction chapter. The next one I want to mention to you, the essay question is a defined pocket, classification and pathogenesis of the pocket. These are the important question I want to tell to you. And 4th, I want to mention to you, you should know CAL, clinical attachment, assess probing pocket depth. You should know this thing for clinical application actually, and you should know it out how to use this thing in the gingival recession and gingival enlargement. And on applying all this thing, in the case sheet you should write, you should write about probing, that is a probing pocket depth, and the CAL also should be in the case sheet. Correlating with this thing, you have to write about Russell's periodontal index. It's very important for you. So these are the clinical tips and also your examination point of tips I am giving to you. And a very important one I want to do it out means, I want to one important question to you, my dear students. Which are the conditions where there is a without pocket formation, there is a bone loss is there. This is one of the questions most of the examiners will ask you, tricky question, how do you understand this subject to the depth? You know it out. The one condition is a trauma from occlusion. The next chapter will be there, trauma from occlusion. Why there is a without pocket formation, periodontal pocket formation, probing depth will be more than 3. There is a bone loss can be seen in the radiography. The reason for that thing is, the pathway of the inflammation is differ from our normal inflammation, and in the traumatic inflammation the pathway is following like a Glickman concept. Glickman concept is very important question to you during your UG studies and PG studies also. Okay, so in that condition, first condition is trauma from occlusion. The pathway of the inflammation is totally different, directed towards the 2 zones will be the zone of irritation, zone of co-destruction. Irritation means that is like a plaque on calculus, that's a whatever the etiological, main etiology. Zone of co-destruction is, that is from trauma, from occlusion, that will be coming out in the thing. That's the one question I want to mention to you. Second one is acute necrotizing ulcerative gingivitis. You may all know it out. This thing, trench mouth, they are called as trench mouth. This ANAC become, what you called as, this ANAC become NP, that is necrotizing periodontitis. You can able to see without pocket formation, there is only, you can able to see the bone will be custom formation, the bone will be taken place in the area. Why means, the ANAC means the falsely invading disease. You know, spirochetes are very speedy movement things. You can see in the electron microscope only. So what will happen, you know it out, I told you, very important, in your pocket chapter, one important point has been mentioned. For the further progression of the pocket and the pathogenesis, they mentioned this line, there should be viable 1 or 2 viable cells in the base of the pocket. You know it out, this is the pin, I will put it like that, it looks like that. The junctional epithelium should be, 3 portions will be there. This is the lowest, middle and the highest portion. This is for protection, this is for attachment, this is for movements will be there. You can able to 1 or 2 viable cells will be there for the further progression of the pocket. That is very important, but in this condition, due to the ANAC, spirochetes, they can destroy all the, degenerate all the, ANAC means acute necrotizing ulcerative gingivitis, necrotizing the epithelium. That's the reason the subcustom only formation, the bone will be, there will be subcustom formation will be there. So you can't able to find out the pocket in this condition. So these are the clinical application I want to mention to you. Another one important thing, you know it out, the periodontal ligament principal fibers will be there, you know it out, apical fibers will be there. Even the apical fibers will be lastly affected, the tooth will go for grade 3 mobility, because apical fundus, the blood supply will be there, that has been cut out, so the tooth can't able to stay there. Even it stay there, mean ankylosing will be taken place, not now it will not useful to you. That's one point. Second important point, you know it out, the fibers will be the septal fibers. We have a septum in the bone. Above the septum, between the 2 teeth, one between the 2 teeth, septal fibers. The transseptal fibers, even the destruction of the pocket will be very seriously, depth of the pocket will be increasing, severity and progression will be there. The transseptal fiber will regenerate itself and connected to the adjacent tooth itself. These are the 2 important points I want to make it a note of this thing for understanding the subject. Okay. So from this thing, I want to conclude my chapter and telling thank you very much, my dears, for attending my class. If any doubt is there, please contact us. We will try to clarify those things. Thank you very much.